Cardiovascular collapse is severe hypertension caused by acute cardiac dysfunction or loss of vascular tone, leading to cerebral hypoperfusion and loss of consciousness. If circulation restores spontaneously, it is classified as syncope. If it does not, it progresses to cardiac arrest and may result in death if not reversed. Sudden cardiac arrest is abrupt loss of cardiac function due to ventricular fibrillation, ventricular tachycardia, asystole, or pump failure. Survival in out-of-hospital sudden cardiac arrest is less than 10%, with most patients dying before hospital arrival. Sudden cardiac death is defined as unexpected death within 1 hour of symptoms if witnessed, or within 24 hours if unwitnessed. Cardiovascular collapse, cardiac arrest, and sudden cardiac death differ in reversibility, requirement of intervention, and outcome. Sudden cardiac arrest accounts for 15% of all deaths and nearly half of all cardiac deaths globally. Incidence increases with age, with higher rates in males and racial disparities showing higher risk in Black populations. Major risk factors include coronary artery disease, heart failure, hypertension, diabetes, smoking, and chronic kidney disease. Electrocardiographic markers, such as prolonged QT interval and early repolarization, increase arrhythmic risk. Most sudden cardiac deaths are caused by coronary artery disease, leading to acute ischemia and ventricular fibrillation. Cardiomyopathies contribute through fibrosis and electrical instability, creating reentrant ventricular tachycardia. Inherited channelopathies like Brugada syndrome and long QT syndrome can cause sudden arrhythmic death in structurally normal hearts. Valvular disease and structural abnormalities account for a smaller proportion of sudden cardiac deaths. The rhythm of arrest has shifted over time from ventricular fibrillation to pulseless electrical activity and asystole. Survival is highest in ventricular fibrillation at 20 to 25% and lowest in asystole below 5%. Coronary artery disease triggers sudden death through acute myocardial infarction or SCAR-related reentrant circuits. Cardiomyopathies increase risk through myocardial stretch, fibrosis, and electrical remodeling. Most cardiac arrests occur at home with delayed emergency response and reduced chance of ventricular fibrillation rhythm. Chain of survival includes recognition, early CPR, early defibrillation, and advanced cardiac life support. Chest compressions should be performed at 100 to 120 per minute, with depth of 5 centimeters and full recoil. Shockable rhythms require immediate defibrillation at 200 joules biphasic, followed by continued CPR. Epinephrine 1 milligram every 3 to 5 minutes and amiodarone are used in refractory ventricular fibrillation. Non-shockable rhythms like pulseless electrical activity require CPR and correction of reversible causes. Reversible causes include hypoxia, hypovolemia, hyperkalemia, hypothermia, tension pneumothorax, and tamponade. Post-cardiac arrest care focuses on oxygenation, perfusion, and urgent evaluation for myocardial infarction. Targeted temperature management between 32 to 36 degrees Celsius is used for comatose survivors. Long-term evaluation includes echocardiography, cardiac magnetic resonance imaging, and genetic testing when indicated. Implantable cardioverter defibrillators reduce mortality in high-risk patients with low ejection fraction or prior ventricular arrhythmia. Secondary prevention (ICD) is indicated after survived ventricular fibrillation or ventricular tachycardia without reversible cause. Primary prevention (ICD) is used in heart failure with ejection fraction, below 35% despite optimal therapy. Most sudden cardiac deaths occur in patients without known severe heart dysfunction, making prediction challenging. Lifestyle modification, including smoking cessation, exercise, and Mediterranean diet, reduces population-level sudden cardiac death risk. Sudden cardiac arrest requires immediate recognition and defibrillation, as survival decreases rapidly with each minute of delay.